What I'm going to try to show is a very statewide perspective, but I think very similar to problems we're facing around the world, that costs are rising at an unsustainable rate, care is not often optimal, and value is missing in some of the projects that we've created and some of the projects that we are now trying to put in. Palliative care, alongside cross-out oncology and substitute cardiology, any specialty you want, offers practical ways to improve health quality of care and value. Show a little bit about how to do this together, and then show you some examples from the real world of how we're trying to change the political and economic landscape in the States to further value palliative care. With the American Society of Clinical Oncology, the Choosely-Wising Initiative, an Institute of Medicine report that will be out the first week in September. An Institute of Medicine report that will be out the first week in September that says, this is how we are going to create a sustainable cancer care system, and it's strongly in favor of palliative care. So how many of you are palliative care practitioners? Well, you're assured a job future. So this is why we got into palliative care. And you can see that every symptom goes down. 30 consecutive patients, pain, nausea, depression, anxiety, shortness of breath. You measure it 24 to 48 hours after the consultation or the transfer to our unit, and it goes down. Exciting, no? Exciting to me as a practitioner. Good stuff. This is why we got into palliative care, because we like to fix things. And then we published the first article showing that a high-volume specialist palliative care unit and team may reduce in-hospital end-of-life care costs. So not only do symptoms go down, people live about the same or longer, but it saves money. It's a good thing, right? My phone rang off the hook for about 2 weeks before this came out. Not with, OMG, what great work, but OMG, how are you going to sell this to the American public? Sounds a little bit like your Liverpool Pathways program, right? Wait, you take good care of people, you have a plan for them, they live just as long, and their symptoms are better. You're just saving money on the backs of the poor and disabled and the elderly. Anybody been through those ringers? I have. And then we published the same data with a slightly different analysis in the Wall Street Journal. So we had a reporter live with us for 2 weeks, and the headline was, "Unlikely way to cut hospital costs, comfort the dying." And we showed that equal survival, better symptom control, $7,000 less in their 5 days of life if they were transferred to a palliative care unit. $7,000. Did my phone ring off the hook? You bet it did. We'd been struggling for 10 years trying to get through the Center to Advance Palliative Care and through OSI, trying to get a purchase in the American medical boardroom for chief execs to say palliative care is a good thing. And you had a collection of a few people here who did it and a few people there, and we all were doing good work with patients. My phone rang off the hook for about a week with, "Hello, I'm the chief executive officer of a small hospital in Connecticut, about 250 beds, and I'd like to send a team down to learn how to do this. What do you call it? Palliative care?" Of course I want to take better care of people. Saving money is a good thing, and you are exactly right. You're so right. It's gone from it's good if it works to it's good if it works and doesn't cost any more, or even better, saves money. So we saw an immediate blip in our training programs for people who are going to come and learn how to do palliative care. It went up exponentially. And it was people from hospitals where the CFO or the CEO would cobble together a group of people and send them down to us to learn how to do this palliative care, to take better care of people, but really to save money. It was a fascinating time. It still is. So, but this is why it's become critically important. So this is the U.S. for this. This is the cancer cost trajectory. There are more old people. There are sicker people. They're living longer. I'll just put these on the website, so it's rather than copying down references, they'll be there. Is that a sustainable curve? No, no way. That's where we talked about you can't flatten the curve or make it go down. You have to talk about bending the cost curve. This is the cost of insurance for a family of 4, $7,000, and in a decade, more than doubled in the US. And the contribution that the families gave went from 1,700 to over 4,000. Is that a sustainable curve? No, not at all. And this is where we are in terms of dollars spent per year per person on health care. US wins this one, hands down, $8,100 per person. Do we have better care? No. You get better care in many countries than the US, at least more equitable care. And then we start talking about value. Let's say you're the head of a big insurance program like Aetna or United Healthcare in the US, or Medicare. Or God forbid your dreams should be answered and you wake up and you are the head of the NHS. And you have to make funding decisions. And the cardiologists come and say, well, look what we've done to heart disease. And you're a cancer doctor saying, oh, we're getting there. We're getting there. What's value in healthcare? Then you'd say, well, not only is there probably a lot of spending that might be better spent elsewhere, take the money in cancer and put it in cardiology, but there's extreme variation. And there's variation here, mostly by postcode, but same thing in the US. This is Medicare spending per beneficiary, and you can see it varies a lot from the dark blue to the light blue. And this is where people get chemotherapy in their last 2 weeks of life, when it's very unlikely to be helpful. So you've got pancreas cancer. If you're getting chemotherapy on your deathbed, probably not a good thing. The brown areas are where over 10% of people are getting chemotherapy in their last 2 weeks of life. Not explainable by anything other than something non-medical. You also have, in terms of value, the fact that 65% of all medical care costs go to 10% of the population. Slightly different, but not a whole lot different here in the UK. But the top 1% use very much the most, and half the people have minimal medical expenses at all. This is part of the objection to Obamacare as it is in the US, because I'm not going to get sick, right? And then you've got the cancer drug explosion. This is my field. $50 billion a year in revenue, and we're now number one, much over heart disease in terms of the drugs cost for anything. 70% are sales from projects in the last 10 years. And since 2005, 90% of the cancer drugs cost more than $20,000 per 12 weeks. And the ones that have been approved in the UK and in the Eurozone cost almost the same. You haven't approved as many, but the cost per milligram of Herceptin is about the same. There's absolutely no correlation of pricing and absolute benefits and event-free survival. And just get prepared, because when Bruce and I last counted, there are 200 or more new molecules that do something good to somebody that a drug company wants to sell. So those are some of the pressures on the system. You've got drugs. As a cancer doctor and as a breast cancer doctor, I use a lot of paclitaxel or Taxol, and it's $60 a dose. And then you've got all these other drugs that may be no better, like ixabepilone. It's no better, and it's $5,000 to $10,000 a dose. And those are the drug prices that companies are expecting someone to pay. But it's not just drugs like melanoma drugs, $120,000 for a course of treatment, or an immune therapy called Provenge for $93,000 for one treatment. It makes you live longer. You live 4 to 5 months longer. But is $93,000 the amount we should spend on it? Good question. And it's not just cancer. For those of you who treat pulmonary hypertension and keep people alive with pulmonary hypertension, vascular relaxers like Flolan and Remodulin are $100,000 a year or more. And we now see everyone who gets a left ventricular assist device, an artificial heart. And the cost of keeping somebody alive with a heart is $450,000 per year. Is that worthwhile? Probably is if you're the person with the new heart, or if it bridges you to a heart transplant. So that's some of the cost pressures. Here's some of the quality of care measures. So Sidney D is a wonderful health researcher that I work with newly at Johns Hopkins, and she and Colleen Apolso, one of the palliative care nurses, looked at just a snapshot of people that were being cared for in the sickest part of the oncology hospital. 61 people, 26% were on a ventilator, 57% died on that hospitalization. Only 40% had any goals of care discussion in the chart. Only 7% had any advanced directives on file. At our own institution, where I'd come from to Johns Hopkins, we had that up to about 30 to 40%, but not 100%. 34% died in the hospital, and about a third of patients got chemotherapy in their last 2 weeks of life, when it's very unlikely to do any good, more likely to damage your immune system and make you feel bad. So that's the sort of quality that we're looking at our own institution nationwide for Medicare patients, so being over 65 and having lung cancer, for instance. Your chance of being hospitalized, no matter whether you're in a comprehensive cancer center or not, your chance of being hospitalized is 60% in your last month of life. Chance of being in the ICU is 25%. Who among us, raise your hands, who would like to die in the ICU on a ventilator? Nobody? Who would like to die at home surrounded by your family and friends with your dog on your lap? A few more hands for that. Who doesn't want to die at all? Okay. All right. Like Woody Allen said, I don't want to be remembered by my work. I want to be remembered by being immortal. So another point. So we work closely with the American Cancer Society. Did anyone on the care team ask what's important to you or your family in terms of quality of life before you started treatment? Did anybody ask the question, what's important to you? No, we don't do that. 29% said yes. You see on my coat here, this little hope button by Anna Ferguson, one of our heme malignancy nurses. It's not, well, we're going to cure cancer so you don't need hope, or there's always some hope left. What we're trying to do with this campaign is to get somebody on every visit to ask, what are you hoping for? Or what are you hoping for? And just trying to engage people in the conversation about what's important to you. Seems to be working. You walk through the oncology clinic and you hear those words pretty frequently now. So there's some of the things. 25% of all Medicare funds are spent in the last year of life, and 9% is in the last month of life. If we could drop hospitalizations from 60% to 30%, we could save a few billion. And much of the pattern of care is under my control as an oncologist, just speaking cancer-wise. So we wrote up this missive for the New England Journal, Bending the Cost Curve in Cancer Care. And you'd be surprised at how many of them involve palliative care. For most solid tumors, limit second and third line therapies to a single type of drug rather than giving 3 drugs in a row. More toxicity equals survival. For patients with cancer that's progressed on treatment, limit future chemotherapy to people who can walk into the clinic, provided they could walk before, because giving chemotherapy to people who are bed-bound or wheelchair-bound, if they're there because of the disease, doesn't improve their survival or their quality of life or anything. But it's just very hard to look another human being in the eye and say, I'm sorry, there's nothing more medical science can do to help you against your disease. So these are some of the things we're trying to teach oncologists to do. For patients not responding to 3 further regimens, further cancer-directed therapy is on clinical trials. This is not 3 strikes and you're out. You had 3 different types of chemo. It's the last 2 treatments you got didn't work, and the next one has almost no chance of benefiting you and a 20% chance of causing significant side effects, I don't think you should take it. That's the script we're trying to give people rather than just 3 strikes and you're out. And then some attitudes besides practices: acknowledge that we drive the costs of care by what we do and what we, more specifically, what we don't do. We don't have conversations with people, and I'll come back to that. And we need to get a little bit more realistic about expectations and then start doing end-of-life non-chemotherapy-oriented palliative care and cost-effectiveness. So some of the ground rules we set up for this discussion: everything's on the table. You have to accept data where it exists. Clinical trials are always exempt. Curative care, exempt. Doesn't matter. If you can cure some 17-year-old with Hopkins disease, I don't care if you spend $2 million doing it. Go ahead and do it. How about hospitalizing cancer patients? So I work at a small rural hospital, and one of the cancer doctors there is notorious for giving people chemotherapy right until they die. And I was seeing this patient for terrible pain, and he'd been through 5 different chemotherapy regimens. And he's having toxicity from the chemotherapy, and there's absolutely no proven benefit to it at this point, because his cancer's already grown on all the good drugs. So I call up his oncologist and say, explain the situation, and his oncologist says, "You want me to just give up on him?" So I call the hospital administrator and say, "I think you should be aware that one of your oncologists is practicing way off the mark, way off the practice guidelines. And he's giving chemotherapy to people who aren't benefiting from it, and they're just ending up with side effects, and they're ending up in your hospital." The hospital administrator said, "Well, this doctor is responsible for most of our oncology admissions. He's keeping our beds full in oncology. I don't really think we can change that." So it's complicated. People have to make money doing this, and we don't like to have difficult discussions. So why palliative care? It's good and sometimes better care. It can allow people to live longer. It doesn't kill people off. We finally settled that. Hospitals are full, often of dying people, and who don't want to be there. If they knew there was some alternative, and we need some way to bend this cost curve down like this to preserve the good parts, but add in parts that will improve care. And palliative care offers the quadrifecta or home run: better patient experience with better quality of care, better symptom management, better quality of care with fewer hospitalizations towards the end of life, equal or better survival, and it saves money. There's not been a single study that shows anything different. So you folks all know what hospice is. And what's really interesting working in inner city Baltimore is the perception of hospice. It's a place you go to die. Sort of like the Middle Ages in Europe. It is a place you go to die because of the Joseph Ritchie Hospice, which was started during the AIDS epidemic in the 80s and 90s, and it's a place where poor people and IV drug users go when no one else can take them and they go to die. So you have to know what your own concept is of hospice before you recommend it. Palliative care, on the other hand, you all know about, and we have our own Cicely Saunders here, but the words that resonate are to provide an extra layer of support. 90% of the US public has no idea what palliative care means. 90%. When you describe it, it's what they want. And the words that resonate are providing an extra layer of support. So the data are sufficient that the American Society of Clinical Oncology now recommends it from the get-go for anybody who's seriously ill. So when we looked at the data, we said that it should start at the beginning. Let me go through some of the evidence. So this is a randomized clinical trial that Marie Bakitis did at Dartmouth University in upstate rural Vermont and New Hampshire, and it was a nursing intervention. So we had a trained nurse educator meet with patients and families 2 times a week for 6 weeks, Project Enable, and interestingly enough, no medical intervention, nobody going to the house, nobody fixing symptoms, but telling patients it's okay to complain, getting people to engage their practitioners, getting their symptoms managed, and their quality of life was better. This is this one used in the States. The fact it was better, their symptoms were better, and their depression was less in a randomized controlled trial. Surprisingly enough, this is a usual care curve. This is the intervention curve. Just a nursing intervention allowed people to live longer. The p-value for this is 0.14. Marie wishes she'd stop the study right about there, because that's about a 3-month difference in survival by having your symptoms managed. 3 months. And this is the trial that changed the landscape for lung cancer patients. So this was done at Mass General, 151 people with lung cancer that couldn't be cured, randomized at the time of diagnosis. So you weren't seeing them as we see people with 9 days left to live. They were randomized at the time of diagnosis to usual care and usual care plus the palliative care team. That's the red here. And if you had a better understanding of prognosis, you understood the goals of care, you end up using less IV chemotherapy in the last 60 days of life, getting less aggressive end-of-life care, less resuscitation and more hospice, and used hospice for longer, and lo and behold, those people lived almost 3 months longer. Consistent with, if you have your symptoms relieved, you get better survival. It's also consistent with, if you don't have the palliative care team protecting you from 4th and 5th line chemotherapy, you're getting 4th and 5th line chemotherapy, which has almost no chance of benefit and probably substantial chance of harm. And their FACT scores or quality of life scores were better. And having this meeting with the palliative care team once a month, telling them what their prognosis was, you think that made them depressed? Nah. In fact, depression was better, anxiety was better, total quality of life scores were better. Hospice, too, seems to lead to better survival. There are no randomized trials of hospice anywhere since 1980, published in 84, which didn't show any difference. But that was way before we knew what to do with hospice. So this is a well-designed study, good comparative effectiveness studies, and if you have pancreas cancer and use hospice for even 1 day, your chance of living longer is substantial. 21 days. Erlotinib or Tarceva pills were approved by our FDA for an average survival benefit of 7 days. This is 21 days. There's not a single study showing worse survival with any form of palliative or hospice care. This is lung cancer patients divided up into those who used hospice and those who didn't. Which curve would you rather be on? Which survival curve? You'd rather be on the one to the right, and that's the people who got hospice. They didn't forego chemotherapy. You use chemotherapy when it makes sense, but you start thinking about and planning these things early on. So that was all well and good. This, the clinical benefits are there. Let's look at the things that came after we did our study showing the benefit of inpatient units. And these are 2 studies done at Kaiser Permanente, which is a large health maintenance organization in the US. So much like the NHS here, it not only runs hospitals, runs outpatient clinics, and it's the insurer as well. It's similar to the NHS. And this is identifying outpatients who were seriously ill, all of whom were expected to live less than 2 months, and randomizing them to usual care versus usual care plus an interdisciplinary palliative care team. A doctor, a nurse, social worker, and a chaplain. Intervention's the same in both arms. And their survival was equally as good, better communication, a lot less emergency room use, a lot more use of advanced directives, a lot more people dying where they wanted to be in the group that got interdisciplinary palliative care. But what really caught everybody's eye was it saves Kaiser Permanente $5,000 to $7,000 per month. Or not per month, per member. So this, even taking into account the enormous sums you pay to the palliative care physician, right? Enormous sums, but not enough. Enormous. And this is the Jennifer Temmel's lung cancer trial. So this is the curve that did so much better. Even when you factor in the palliative care, $2,000 less per person because of avoided hospitalizations, and slightly because of less use of chemotherapy. In fact, this is from a manuscript that's coming out shortly. I've put together a running tally of everything that's looked at usual care versus usual care plus interdisciplinary palliative care. It's always usual care plus interdisciplinary palliative care that saves money. I thought when we started our project we might save 5% on an inpatient hospitalization. Turns out it's 50%. It's exactly the same on some data that we just generated at Johns Hopkins. Be wary, there's one study that's different, and this one I put in yellow for caution. This is from Germany. Germany has started putting outpatient palliative care programs and inpatient palliative care units more geographically dispersed. And the study looked at people who used palliative care even once versus those who didn't, matched disease by disease. So comparative effectiveness study. And the good news was more people had opioid prescriptions. If you saw the palliative care team at least once, you're more likely to get an opiate. However, you were more likely to die in the hospital. And you were more likely to get chemotherapy in the last 2 weeks of life, or very close to the end of life, and the total costs were actually several thousand euros higher. So it says that just adding palliative care on top of an existing system might not be as good as thinking about a whole system strategy of let's add palliative care, but let's work on communication, let's work on people's expectations, let's work on home care services as well. So this is Don Quixote tilting at windmills up there. So how do you actually put all that in practice? That's a fair amount of data, all in support of palliative care, and yet it remains underfunded, underutilized. How do you actually do this? Basically, transferring services away from the hospital to needed home care. So we have been at this for a while, and a lot of this presentation comes from the Cancer Business Summit. There's a business meeting about cancer each year, and it includes insurance executives, it includes people from big corporations who have to fund the insurance. So they understand that all of this is unsustainable as it is. And luckily the tide is changing a little bit in the US. This is something that I, as a liberal democratic person, might say. Each of us must have to assume responsibility to do an advance directive. We have to increase medical education to more specifically address end-of-life care issues and expand both hospice and palliative care. But that's not me. That's surgeon and very conservative, very Republican, very much a private heart surgeon, U.S. Senator Bill Frist, now saying this. That's how much the tide can turn, so that you've got both sides of the spectrum saying, we need to find a way to do things differently. So how are we approaching this? We have bills in the Congress to expand palliative care education, and we are actually next Friday hosting a whole bunch of congressional delegates, congressmen and women and senators, at our own institution and having them talk to our families and talk to our administrators. That's why the gulp is there, because I hope it goes well. Otherwise, our program's screwed. We have Maryland bills, so statewide, advocating palliative care, and we're setting up 5 statewide pilot projects. And we're increasing our fellowship training to make more palliative care people. So none of this is a done deal by any stretch of the imagination. So add those initiatives to something that's happening in medicine around the world, and medicine is finally taking some ethical responsibility for healthcare reform. And so Howard Brody said every branch of medicine should come up with 5 things they do that don't make a whole lot of sense that could save money with. The top 5 lists. So we've created the top 5 in oncology and broadcasting these widely to all oncologists. One is, don't treat people who are really sick from their cancer unless they've got a very responsive disease. You've got myeloma, You've got HER2 positive breast cancer. Those people, you can actually see them get better in a week and go back to normal activity. But somebody who's already had 2 treatments for pancreas cancer, is in a wheelchair, or as some of my patients have done, hide their crutches behind the door so I won't see them. They're not going to get better with chemotherapy, and it means I have to have a discussion with them about what their options are and have a trigger so that when you're thinking second or third line chemotherapy, or your second heart stent, or your second hospitalization for congestive heart failure, that should be a trigger point to start having some of these difficult discussions. And then you co-brand your own local initiatives with these national initiatives. You put on your social marketing hat and think about co-branding. So the American Academy of Hospice and Palliative Medicine came up with its own top 5. Don't recommend putting in a feeding tube for somebody with advanced dementia. Not everyone needs to die with a feeding tube. Don't delay palliative care, start it early. So those are the top 5 things we could come up with. Do a single fraction for painful bones that hurt due to cancer rather than 10. And even medicine is changing. So this is from the Annals of Internal Medicine. This is the American College of Physicians ethical response. How many ethicists are here? Nobody? Oh, I can relax then. No, ethics has been really charged. Is it right to withhold care from one person so that 99 can benefit? I don't know the answer to that, but that's ultimately much of what we do with cost effectiveness comes down to. But physicians now have a responsibility to practice effective and efficient healthcare and to use healthcare resources responsibly. Parsimonious care that utilizes the most efficient means is better. So now a statement by the US body. How many of you have direct hands-on care with patients? Do you all know Bodertha's rule of diagnostic reasoning? My wife's name is Joanne Bodertha, an old Welsh name. Doing a diagnostic test is like picking your nose in public. Before you do it, figure out what you're going to do if you find something. Do I really need that CAT scan? Do I really need that metabolic panel in the morning? So how do we make this a practical reality? These are what I try to teach oncologists. We don't do this. And it's about communication. So 60% of medical oncologists like me prefer not to have the hard conversations about resuscitation, advanced medical directives, hospice, until there aren't any more treatment options left. 60%. Half of all lung cancer patients haven't had any of their doctors mention hospice 2 months before they die. And oncologists like me document any end-of-life discussion in 27% of lung cancer patients, all of whom die. And when it happens, it's 33 days before death, and only half the time is with an oncologist. It's really hard to look another human being in the eye and say, I'm sorry, but there's nothing more we can do to make your disease get better. It's really hard, and we hate doing it. So that's why, and we wrote this editorial in the New England Journal last November, when Jane Weeks showed that 3/4 of cancer patients who are incurable think that a person like them could be cured with chemotherapy. If that's what you're expecting, it may come as a huge surprise to know that you can't be cured. And no one's done this study in the UK, but I would bet you'd find exactly the same thing, because oncologists like me have a hard time doing this. So how do you do it? Ask, tell, ask. You ask permission, you tell in understandable language, you ask what you're understanding in the situation. These are some of the prompts we're trying to give medical oncologists to teach them these scripts. What's important to you? And probably the 3 most important words in the English medical language, tell me more. Somebody says, well, I know I can be cured of this, or you can't let him die. Rather than slapping the person and saying, well, he's going to die anyway, or saying, how stupid can you be? You've been getting chemo for 6 months and you're still not any better. You know, it doesn't work. You just have to say, tell me more, so you can understand from their perspective what's going to happen to them. And then you offer clarification treatment goals. I'll skip that. And then what we're trying to do at our own institution is have a script. that every healthcare provider knows, that an oncologist knows, a cardiologist knows, a kidney specialist knows, a lung specialist knows. If you're in the hospital for the third time for your emphysema in a year, and it took you a week to get off the ventilator last time, we should be having a tough discussion. And people have a script. If you go in and tell somebody, I need to take out your appendix, you have a script for that, believe me. You're giving somebody adjuvant chemotherapy after surgery, you got a script for that. We need a script for this. And if this is a serious illness, and I've learned from my experience that there's some things that we should cover because they often get neglected. And let's do them now while you're still well and able to do them. Do you have a will? It's an easy, simple one to start with, and that's medically safe. Do you have a living will or advance directive? How do you feel about resuscitation? And there's some wonderful videos that you can show people now which will make people choose the right thing about resuscitation. Who do you want to make medical decisions for you? You're going to have this in the clouds, hopefully for all your palliative care patients and hopefully for the whole system. But who's your power of medical attorney? Are there spiritual issues that you should address? I talked to somebody a few weeks ago and said, lung cancer, newly diagnosed, brain mets. And I said, is religion or spirituality important to you? And he broke down in tears, sitting there on the bed sobbing. And his wife said, he hasn't forgiven God since God took his brother with acute leukemia 28 years ago. But never asked the question, never would have found out what was really distressing him. And you don't want me helping you with your spiritual issues. That's a ticket to hell. But we work very closely with chaplains of all faiths, and getting a chaplain involved to address some of these spiritual and existential issues is really critical to help people adjust. Are there any family issues? Anybody you need to make up with? Have you met with hospice yet? And we're trying to get every oncologist to start thinking, let's have a hospice information visit when you have 3 to 6 months left to live. Not 3 days before you die, or a month before you die, but 3 to 6 months before you die. Have you thought about where you would like to be for your death? And let's start doing a life review, sort of dignity therapy. What you would like to have people remember you by. There's still a chance you could be alive 3 years from now. Not taking away that, but let's write stuff down. Let's do some DVDs. I've never had a person come back and say, you know, Smith, 3 years ago, you told me that I had to do all this stuff, and here I am. They never come back and say, darn you, you made me waste 3 weeks. They say, that was the most important thing I did in that whole year. And write it down. So this is what will be, again, endorsed by the Institute of Medicine, is you sit with a computer or you sit with a piece of paper and you write down the name, the diagnosis, their name, the diagnosis, the stage, the treatment, the prognosis, what their options were, these important issues, what the follow-up will be, and when to call the office and a number. Very few physicians write stuff down. They'll come in and say, you have adenocarcinoma of the pancreas, it's grade 3 out of 3, it's spread to 4 lymph nodes, and we need to do surgery and radiation therapy. Do you have any questions? No. As opposed to, now that we've discussed this, tell me your understanding of the situation. It's ask permission, tell, ask again. If you write stuff down, it saves time, actually. One of my friends did this in practice, Peter Eisenberg in Marin County outside of San Francisco. He found that it saved their practitioners 5 minutes for every new consultation when they wrote stuff down, because they were in control of the interview. So it saved time for them, as well as dramatically increased understanding. So we're working on this by having this major push at my professional society for Ask Till Ask. We hope to have, by the end of the year, decision aids for the top 20 cancers online, so that you can go and get real information about brain tumors, lung cancer, how long I might live, how long I might live with or without chemotherapy, what are the top 4 side effects, and have those prompts. If you're reading this about lung cancer, you should be thinking about these other issues. We're working with the National Coalition of Cancer Survivors, and we've got an app that's almost ready to go, so when the patient comes into the exam room, he or she can click on their iPhone and say, I'm supposed to ask you these 5 questions. And we're trying to relabel it from the death panel to the good planning panel. And for incentives, there are a couple of health systems that are trying what are called G codes. You get paid money for actually sitting down and having this difficult discussion with people. So when I tell this to oncologists, they say, oh, people don't want that information. Bzz. People do want that information, 90% do. It'll make people depressed. Bzz. It'll take away their hope. Bzz. This is a study that we did with 27 consecutive seriously ill cancer patients. And we gave them their most honest prognostic information. Sir, based on your situation, you probably have, on average, about 3 months to live, give or take a month or 2, with no chance of living a year. But let's talk about some of these other important issues. What do you think happened to their hope? Right? It didn't change. No matter how hard I tried, I couldn't stamp out people's hope. And all the data in the 2 studies that have been done show that the more honest you are with people, the more you actually engender hope. It's a fascinating, paradoxical piece. I've showed you it doesn't make people die sooner. Oh, we can't tell people how long they have to live. Baloney. We're actually pretty good at guessing. We just overestimate by a factor of 5. 5. So if the doctor says you've got 5 days to live, you can probably cancel your Sunday newspaper. Sorry. Or it's not culturally appropriate. That's also baloney. I know you're having walked from downtown out to here, you're in a multi-ethnic, multi-religion, everybody lives here. And it's sort of like any big city. So the only way you're going to find out what's culturally appropriate is to ask, how much do you want to know about your illness? So families in Tajikistan will tell me, don't tell dad, you tell the family first, or you tell the oldest sons first. And sometimes that's right, sometimes it's not. You just have to ask. And then you set up a symptom assessment, which I know you do. So you ask, are you depressed? And there's some fascinating data using in antidepressants in depression, treating with a single dose of ketamine. Have you done this? No, it's really fascinating that a single dose of ketamine may actually get rid of depression for weeks on end. It's fascinating, just a single dose. And you can use ginseng, American ginseng, to fight fatigue. Randomized clinical trial evidence. And dexamethasone, a steroid, actually helps people's fatigue. So this is palliative care pearls. But you have to have, for each of these symptoms, you have to have a way to fix them. So we have this on our electronic medical record, so I can click on each one of these things, and then it automatically leads me to a palliative care algorithm that I can manage them by. Not quite as fancy as I'd like it, but getting there. What's really cool about the electronic medical record is it's automated our chaplain consults. Anybody here does chaplain? Anybody here related to a religion? Religion or chaplain?
We work quite a lot with them, yeah.
I'm sorry? You work closely with them, but they're not here. Whew, also good. So we just ask, is religion important to you? Would you like to see a chaplain? And then if I click on the electronic medical record, it'll automatically search their electronic medical record and find out what religion they belong to and page the chaplain to them. It's the coolest thing we've done in a year and a half at Hopkins. Because as you fix their physical symptom, breathing like that and in terrible pain, they've got some other big issues that are existential and spiritual that you ought to know about. In fact, people whose spiritual needs were supported by the medical team use hospice more and have higher quality of life, and in fact are less readmitted to the hospital. So that's a big argument that I use to my medical administration, why they should pay for more chaplains. And then we use the palliative prognostic scale, and the big thing is if somebody is in bed, can't eat, every study shows they have days to live. And you can point this out to mom or the grandma or the spouse and say, it's not just me, Tom Smith, being mean. This is a predictor that your loved one has a very short time to live, and we ought to take advantage of however many days the good Lord's going to give him. And then you have to have words or a script. It's palliative care is about improving quality of life, providing an extra layer of support. If you say those words, 95% of the American public say they want it. And then we're working with practices to set up some guidelines for this. I'm a guideline sort of person, and you can identify people with average survival less than 6 months pretty easily. This is not the Liverpool pathway for identifying, it's not what happens to them, but just identifying them so that you can have in place the triggers for palliative care consult. Really pretty easy to do. So this is an example of one big health system that's done this. This is US Oncology. It provides 15% of the cancer care in the United States. And these are the survival curves of people on or off the clinical pathway. Red and blue. Are they different? They are exactly equal. These are lung cancer patients, and you can see that the average survival, 50% median survival, is 11 or 12 months, actually better than the US survival. What they do is they limit the chemotherapy to generic drugs rather than the really expensive one. You get first line, second line, third line chemotherapy, but you can't get fourth or fifth line chemotherapy until you call up the lung cancer czaress and she makes a decision about whether it's appropriate or not. So they've changed the front end here. What they've done is up here in the first month, they have somebody meet with them to start talking about hospice, palliative care, and advanced directives. And this is the checklist. If you're going to be the best practice for US Oncology, you have to have somebody in your office document that you've talked about advanced medical directives, use of hospice later, paying attention to symptoms. This is the curve that got everybody's attention. This is the curve that shows these patients cost 1/3 less. Equal survival. They've now gotten their time in hospice up to about 60 days. Equal survival, I'm sure better symptom management, and 1/3 less. And in fact, when you look at colorectal cancer patients, people on the pathway with advanced colorectal cancer live 6 months longer. Again, possibly this is the people off the pathway. These people may be getting more chemotherapy that's not beneficial to them, but look at the cost. It's $100,000 versus $156,000. That's the sort of data that talks to people. So what we're trying to do is, for best practices here, appoint somebody in the office to discuss all these things right up front, limit chemotherapy to that which we can show works, and what we're working through the American Society of Clinical Oncology is this hospice referral for a hospice information visit when you think the person has 3 to 6 months to live. I'll let you know how that works out in about two years. So regardless of what my wife says, oncologists like me are educable. And here's proof of it. So Doug Blaney went back to the University of Michigan. Doug's an oncologist like me. And what he did was he just audited their practice and found how many people with lung cancer, pancreas cancer, gastric cancer are getting chemotherapy within 2 weeks of their death. When it's not likely to help. And just fed back that information to the docs, and it dropped from 50% to 20% literally overnight. So giving people information about their own practices is really key to changing our behavior. Not everything is that easy. This is a project we've been doing with fertility preservation. If you're a young person getting chemotherapy, you should have somebody talk to you about saving some sperm, saving some eggs, maybe banking those things. That's a much more difficult conversation, and it really is much more involved. And even with 3 years of trying, it stayed about 10% of people having any of that done. So if it's a really difficult task, you can't fix it just with communication. I'll skip that one. So there are only three ways to change physicians' behavior. You change the culture, you change the beliefs, you change the incentives. We just finished a project where we identified patients who were palliative care eligible in the emergency room. So with 2 one-hour lectures, we taught people in the emergency room, the whole staff, how to recognize palliative care and hospice eligible patients. And then they would ping us anytime, day or night, and we would try to go down and see that person within 12 hours. Usually during the day, it's within an hour or two. And so we would see them on their first day rather than on their 12th day of hospital admission. And we ended up discharging at least 6 or 7 people before they ever got admitted to the hospital, just by being able to meet them, hold them in the ER long enough where we could arrange the resources at home. Those people didn't come into the hospital because they had a way to be set up to die at home. If you get palliative care involved, the data from the states are that your chance of using hospice goes up by a factor of 10, not 10%, by a factor of 10. And we're starting to give feedback to our referring physicians. This is a project that we just hatched this Monday where we're going to give each individual physician their own practice patterns related to their own end-of-life care patterns. How many people do I actually refer to hospice? I'm sure it's 100%, right? Probably more like 50%. And when do I refer them to hospice? Oh, I'm sure it's with 2 months left to live. Oh, it's probably more like 7 days to live. So that's some of the data, not all the data. It's pretty clear for oncology that palliative care is now alongside is the accepted best practice. All the data suggests equal or better quality of life, fewer symptoms, equal or better survival, and less cost. There's not a single study that shows harms. It's possible to make such programs sustainable. I didn't talk much about social marketing. We can maybe cover that. But you have to put on your social marketing hat and get people to do something that they don't want to do. I'm going to end there, and thank you all for listening. I know it's a little warm day here in London, and you've been very attentive. Thank you.